Good morning and welcome back to day 2 of the February 2018 Advisory Committee on Immunization Practices. So we're going to do a little catch up from yesterday and begin with hepatitis and see if we can address a couple of the issues that we started to address yesterday. And so we're going to start with Dr. Romero.
So good morning. I have no slides. We met last night to address some of the concerns that the voting members had regarding questions of hepatitis A prophylaxis and the use of hepatitis A vaccine in individuals greater than 40 years of age. We have re-wordsmithed the questions, which we think will address some of the concerns. I'd like to remind the voting members that the data that's been presented is all the data that exists at this time, we don't see anything coming forward in the foreseeable future. So Noel will present the questions, and then we'll move forward for 2 votes in 2 parts, and then a VFC vote.
So just to clarify, yesterday we actually discussed 3 issues sort of simultaneously. Today we're going to take one at a time, and I hope that we'll be able to fit this in the hour, but I think we can. 30 minutes. Oh, 30 minutes. Okay.
Okay. Good morning, everyone. So the first question, hepatitis A vaccines should be administered for post-exposure prophylaxis for all persons aged greater than or equal to 12 months. In addition to hepatitis A vaccine, IG may be administered to persons aged greater than 40 years, depending on the provider's risk assessment. Provider guidance will help providers to evaluate the need for IG based on age, immune status and underlying conditions, such as chronic liver disease or immunosuppression, exposure type or risk of transmission, such as restaurant-related cases versus household exposures, and availability of IG. As I presented yesterday, there are numerous hepatitis A outbreaks that have occurred over the last 5 years. Guidance for health departments in the appropriate administration of vaccine and IG in these situations is critical. The second question, hepatitis A vaccine should be administered to infants aged 6 to 11 months of age traveling outside the United States when protection against hepatitis A is recommended. As stated in the current ACIP recommendations for MMR, all persons aged greater than or equal to 6 months who plan to travel or live abroad should ensure that they have acceptable evidence of immunity to measles, rubella, and mumps before travel. Travelers aged greater than or equal to 6 months who do not have acceptable evidence of measles, rubella, and mumps immunity should be vaccinated with MMR vaccine. Before departure from the United States, children aged 6 through 11 months should receive 1 dose of MMR vaccine. Immune globulin and MMR vaccine should not be administered simultaneously. Therefore, infants aged 6 to 11 months who will be traveling internationally who also need protection against hepatitis A should receive a single dose of Hep A vaccine. Infants should then complete the full 2 doses of MMR and hepatitis A vaccines at greater than or equal to 12 months of age as recommended.
Thank you very much. That was really clear and very straightforward, I think. I'm sure that the committee still has some questions, so could we start with the first, and would you like to make the motion for the first, and then we'll have discussion of the first?
Okay, so can we throw
Can you put up the wording?
The first vote?
Oh,
Please. So a motion to accept hepatitis A vaccines should be administered for post-exposure prophylaxis for all persons greater than or equal to 12 months. And in addition to hepatitis A vaccine, IG, or immunoglobulin, may be administered to persons greater than 40 years of age, depending on the provider's risk assessment.
Is there a second?
Second.
Dr. Szilagyi.
So
Okay.
before we start discussion, I just want to say that there were 2 people who signed up for public comment yesterday prior to the hepatitis A votes, and if you would like to speak before this vote, please just go see someone at the back of the table and let them know that you're here. Thank you.
Okay, discussion on question 1. Motion 1. Sorry, Dr. Kimberlin?
I just had a question. Yesterday, I thought it was greater than 50 years of age. Now it's greater than 40. So I'm curious. Was it 40 yesterday?
no, we changed it from 50 to 40, and that was due to concerns regarding immunogenicity in adults over 40. So the underlying use of vaccine is the same. So everyone over 12 months, greater than or equal to 12 months of age would receive vaccine. Then the decision to administer IG over age 40 would be based on provider's risk assessment, giving provider the option to give IG as well from that 40 to 49 age range.
So there was just a reconsideration by the work group of what that risk was in the 40 through 49-year-olds last night?
Yes.
Dr. Atmar?
So, yeah, I think this addressed the concern that I had with the lower immunogenicity that was seen in the small study for the age 40 to 49, where the immunogenicity at 15 days was around 74, 75%. So I think this is an acceptable revision of what was originally proposed.
Dr. Moore?
Just as a reminder, the current recommendation says consider IG above 40. So this is just going back to what the current age cutoff is, rather than going up to 50 as we were considering earlier.
But to clarify, this is adding hepatitis A vaccine as an initial and first a step towards prevention.
Good. Other concerns, questions? Dr. Messonnier.
Yeah, I'm a little confused because I thought the language yesterday was around specifically outbreak response, and none of that sentiment seems to be in this. And so is the intention, even for 1s and 2s to administer vaccines?
So the intention is for any situation where post-exposure prophylaxis is needed. And usually that's either an outbreak situation or a suspected outbreak situation.
Any other questions? Yes, Dr. Hunter.
I was just, do you mind if I ask a question? Are you saying that, this takes away the public, say local public health, ability to only administer IG for a household contact of one person, and if they decide not to give the vaccine to that person, that you're concerned about that, or?
I just feel like a general internist making a decision about IG on a one-to-one basis puts a lot of responsibility on a clinician who, probably doesn't have the context. But if it's done in an outbreak setting, I would presume that public health would be giving additional guidance that would help the clinician make that decision. And so it's the language that's the clinician should make the decision based on X, Y, and Z that seems a little bit, I would think we should wordsmith that a little bit to kind of put language in about the context and the outbreak. It's not the actual recommendation, but it's this provider's risk assessment that makes me a little worried that it puts too much impetus on individual clinician.
But couldn't that be in the guidance? I mean, I think you're absolutely right that actually individual clinicians know remarkably little about hepatitis A management in the post-exposure setting. But by the same token, I think that we can put in the guidance what the consideration should be in choosing the IG or not.
Yeah, I was just asking who, when in the first draft of it, when the provider guidance was below, it implied that the provider individually was supposed to make that assessment. And I think all I'm saying is in the clinical guidance, we probably need to make it clear that it's for an outbreak setting and that it's actually public health that's going to be providing a lot of that guidance.
But in an individual scenario, like say a household, we would probably, it would end up being the clinician, right? Dr. Moore?
So I agree with Dr. Messonnier that public health is involved even in individual cases of hepatitis A where only family members are involved. It's still a notifiable condition, reportable, and the state or local health department would be engaged with the provider to help them make that decision. So I think the intent was that public health would be engaged, that they wouldn't be left on their own, but that surely could be put in the guidance for the providers to make it clear that, by the way, this is also reportable, and when you report it, you can get some help on making a decision.
Dr. Hahn.
Yeah, Dr. Hahn, Chris Hahn, CSTE. I was just going to support what Dr. Moore said. Absolutely, public health is very involved even with individual cases, so I agree in the guidance if it made said language about it. If there's question, or please consult public health, because we would be very engaged.
Dr. Smith.
As a state health official, we don't have local public health. They're all one health department in Arkansas. I feel like the wording here would give us the guidance we needed as an internist. I think this would give me the guidance that I needed as well. But I appreciate the concerns, Nancy, that you've addressed.
Yeah, just to clarify, the reason I was pushing back on this a little bit is that actually people do show up in the office having a post-exposure situation, and often public health doesn't hear about it for a couple of days. And so I think having the guidance there is really important for all clinicians. Dr. Bernstein.
How does somebody's immune status to hepatitis A play into whether or not they need vaccine?
So if they're immunocompromised, they might need the addition of IG depending on their immunodeficiency, and that would also be laid out in the provider guidance with a definition of immunocompromised.
I think the question that may be asked is, what if somebody's previously vaccinated with a complete series?
So if someone has been previously vaccinated, we do not typically recommend additional post-exposure prophylaxis. If someone is, it will say in the guidance though, if immune status, that would be simply a provider decision. That would not be something that we would lay out on an individual, situation.
Dr. Hahn? Sorry, Zahn.
It's all right. Yeah, so not to beat this to death, but to push back gently on what you'd mentioned, Dr. Bennett. If there is someone who comes with hepatitis A or someone who's had an exposure to hepatitis A and they come to a clinician's office, and it's a nationally reportable disease, as soon as they're a case of hepatitis A, really, public health would not want that person leaving the clinic without public health being aware of and having a plan for exactly what happens. And so I think in the guidance, it's nationally reportable, and any decision should be made in conjunction with public health. I mean, it just always should be so, I think so.
Okay, do you think we can call the question? And are we electronic voting or?
We do have slides. Ready with the slide? Yeah. Okay, great.
Okay. So just to remind everyone about what we're voting on. Oops, we lost the wording, but yes. Dr. Atmar, did you?
Is there public comment?
Oh, thank you.
There, yes, thank you.
So we do not have anybody signed up for public comment. The two individuals that signed up yesterday, I don't see in the audience. Anybody? Okay.
All right, so the voting is now open.
Noel, can you read the language one more time just for people? Okay, then let's go around the table then. We'll try again next meeting. I'll make you guys try.
We're going to get a new
vote.
system. Yes. If I have to pay for it myself.
Hepatitis. Okay.
Okay.
I'll read
so thank you. That's great.
Okay.
Okay, so we are voting on question 1, both A and B together, and I'd like to ask Dr. Fry to start and go to your right.
Fry, yes.
Atmar, yes.
Lee, yes.
Belongia, yes.
Moore, yes.
Bernstein, yes.
Walter, yes.
Riley, yes.
Stevens, yes.
Bennett, yes.
Romero, yes.
Szilagyi, yes.
Pellegrini, yes.
Hunter, yes.
Thank you very much, and this motion passes unanimously, and now we'll move on to the second. Dr. Romero, would you like to make a motion?
Yeah, I'd like to make a motion that we vote on hepatitis, question, hepatitis A vaccine should be administered to infants age 6 to 11 months traveling outside the United States when protection against hepatitis A is recommended.
And is there a second? Ms. Pellegrini? Thank you. So discussion is open. Ms. Pellegrini.
Thanks. I didn't mind seconding, but I actually had the question. Can we go back to the guidance language for one moment? I had a question on the last line of it. One more forward. One on infants. There we go. So the last line here is that infants should complete the full 2 doses after 12 months of age. Does that mean they get 1 more, or that they start the series over and get 2 more? So they should start actually a full series. Complete, I think, is a little confusing because it sounds like they actually started it with the under 12 months dose.
Right. That's a good point. Yes, thank you.
And we can certainly clean that up.
Dr. Hunter.
Yeah, on this slide is what I wanted to look at too. It looks like this guidance could almost go in the measles recommendation, the MMR recommendation, rather than the hepatitis A recommendation. And that's the way, especially the way it's written. And I think it's very well written, and it should go somewhere. But when I read it the first time, it struck me, it's like, oh, this seems like we're looking at the measles, mumps, rubella.
So that actually is the measles recommendation. That's why it's in quotes. It's actually from the measles recommendation.
And language that they're suggesting be in the document. These are the work group considerations in the language of the measles recommendations that they're trying to align with.
Dr. Walter.
I'd like to thank the work group for simplifying the language. This is much easier to implement in practice. So.
Dr. Moore?
Yes, we were just trying to make it very clear, since every child is 6 through 11 months who sets foot outside the United States should get an MMR vaccine, and since immune globulin shouldn't be given with MMR vaccine, by default, if you need hepatitis A protection, you need the hepatitis A vaccine. So it makes it very, very simple.
Dr. Kimberlin?
I like the simplicity. I would add, just for kind of being full safe here, it does not actually say to not give immune globulin and hepatitis A. So I would add in there should receive a single dose of hepatitis A vaccine and should not receive immune globulin.
That's very reasonable, yes.
Are you comfortable with that being in the guidance around the language for the recommendation?
Yes, ma'am.
Sorry, this could be a guidance question, but I'm just confused a little bit. Is there going to be a comment on whether or not simultaneous administration would be acceptable? Yesterday it was sort of very specific of hepatitis A and MMR. So in the guidance, would we say? You would
Yes,
say
we can put that in there. I think
Then
that would all be
acceptable.
part of, yes.
Yeah.
Further questions, concerns, issues? Then I think we'll call the question. Dr. Walter, would you like to start and go to your left?
Walter says yes.
Bernstein, yes.
Moore, yes.
Belanger, yes.
Lee, yes.
Atmar, yes.
Fry, yes.
Hunter, yes.
Pellegrini, yes.
Salaji, yes.
Romero, yes.
Bennett, yes.
Stevens, yes.
Riley, yes.
And with that, this motion also passes unanimously. Now we'd like to do VFC. Is that correct? Yes. And we need
Dr. Santoli was here.
Santoli, and we may have gotten done too early.
She was just here. Let me just put
Okay. Thank you. You guys are so efficient. We're not ready. That was great. Nice job.
Let's ask somebody else from the program to do it. Cindy, Melinda, somebody? Thanks.
Thank you, Dr. Weinbein.
Thank you. As we do, we will now look at a VFC resolution for hepatitis A vaccines. As usual, the new language is in yellow on these slides. The purpose of this resolution is to add recommendations for infants ages 6 to 11 months of age traveling to countries outside the United States for which protection against hepatitis A is recommended. Excuse me. And to revise the language regarding post-exposure prophylaxis to match the most current ACIP recommendations. In the eligible groups, infants ages 6 to 11 months of age traveling to countries outside of the United States for which protection against hepatitis A is recommended. And of course, the language for all infants aged 1 to 18 years of age will remain. Oh, and let me turn it over to Dr. Santoli.
Thank you, sorry.
We apologize to Dr. Santoli. We got a little ahead of schedule.
So, and I apologize, you're a pal. I'm sure Cindy said, and you remember from yesterday, the yellow language is what's new, what's white is unchanged. So in the schedule, we revised the first part of the wording, and that's shown in yellow, that all children should receive hepatitis A vaccine at 1 year of age, i.e. 12 to 23 months. Vaccination should be completed according to the license schedules below. Children who are not vaccinated by 2 years of age can be vaccinated at subsequent visits. Catch-up vaccination of unvaccinated children should be administered to children aged 2 through 18 years. The table's unchanged. One of the footnotes is revised to shorten a longer footnote that was put in about Twinrix. This resolution is more than 10 years old, and so things have evolved over that time, so that was changed slightly. Then the recommended intervals section is unchanged. And then the wording for the recommendation for the use of hepatitis A vaccine for post-exposure prophylaxis is modified slightly in order to match more closely with the recommendations that are being voted on and also discussed at this meeting. Healthy persons aged 12 months through 18 years who've been exposed to hepatitis A virus within the prior 14 days and have not received hepatitis A vaccine previously should receive a single dose of hepatitis A vaccine as soon as possible. The hepatitis A vaccine series can be completed with the second dose at least 6 months after the first dose. And then there are selected special categories, and we've added a new selected special category based on the earlier discussion about infants age 6 to 11 months of age traveling to countries outside the United States for which protection against hepatitis A is recommended on CDC's Traveler Health website. Infants should then receive the full 2-dose hepatitis A vaccine series at greater than or equal to 12 months of age as recommended. The second selected special category is unchanged, and it's about the timing of vaccine and immunoglobulin. The recommended dosages is unchanged, and the contraindications and precautions are also unchanged. And then we've added a statement that you probably are familiar with from other resolutions that just says that when an ACIP recommendation is published within 6 months on hepatitis A, that information is included and incorporated by reference.
Thank you. Could I have a motion for the VFC vote? Dr. Romero?
So moved.
Thank you. Second? Dr. Belongia? Thank you. And discussion. Dr. Hunter?
I just want to make sure the mention of not giving hepatitis A after exposure if you've already received the hepatitis A series, that's consistent with what we said before, right?
It should go in the policy statement, so yes. It would be
okay, I just want to make sure that what that said was, I thought that was correct, I just wanted to double check.
Dr. Walter?
Not so much pertinent for this vote, but for MMR, for travel for children under 12 months of age, is that currently covered under VFC?
I don't know that is. We can certainly look at that and bring it forward. I don't know that, I didn't review that before preparing this one.
Yeah, I actually had the same question. I was sort of confused about whether travel vaccines are covered at all under VFC. So if so, when?
I do know that they are included for meningococcal vaccines. For the travelers are considered a risk group. They're included.
I would think we should be consistent for the recommendations. So.
Right, no, I think we certainly are able to cover VFC-eligible children who travel in the VFC program, and it bears going back and looking and seeing if that was written in the MMR, and if not, we could bring it back to the group.
I think it'd just be great for us all to understand the rules a little bit, because I'm not sure we're clear, but it's not really relevant for this vote. So any other discussion, questions? Seeing none, I think we'll call the question, and could we start with Ms. Pellegrini and go to your right?
Pellegrini, yes.
Hunter, yes.
Fry, yes.
Atmar, yes.
Lee, yes.
Belongia, yes.
Moore, yes.
Bernstein, yes.
Walter, yes.
Riley, yes.
Stevens, yes.
Bennett, yes.
Romero, yes.
And Szilagyi, yes.
Thank you very much. So the VFC recommendation is passed unanimously. And now I think we're going to move on to pneumococcal disease, back on our schedule. And I think we'll start with Dr. Lee.
Thanks very much. I'm very pleased today to represent the pneumococcal working group. I first wanted to move the slides. And thank the members of our, esteemed members of our working group. In particular, there's been a lot of expertise that's been provided to this particular topic, and there's a lot of challenging studies and questions that we have to think about together. So acknowledging Nana and Paul, who are my co-ACIP members, all the members of the work group, and in particular, Dr. Pilishvili and Dr. Madanok for their leadership of this work group on the CDC side. So our terms of reference, just for review, are to review the current data on efficacy, effectiveness, immunogenicity, and cost effectiveness of pneumococcal vaccines, to review current recommendations considering up-to-date evidence, including epidemiologic studies, and to assess the strength of that evidence, and then revise or update recommendations for pneumococcal vaccine use as needed. As a reminder, by way of background, in August of 2014, ACIP recommended PCV13 use routinely for adults 65 years and older. At that time, the short-term thought was that the recommendation for universal PCV13 use was warranted, but there was a recognition that in the long term, continued herd effects from the childhood vaccination program might limit the utility of a universal recommendation for older adults. There was uncertainty about the magnitude of the indirect effects at that time, as well as a burden of vaccine-preventable non-bacteremic pneumococcal pneumonia. So additional work was needed. And the recommendation was to reevaluate the decision to routinely use PCV13 among adults 65 and older. There was a really nice research agenda laid out that focused on monitoring pneumococcal disease, both invasive pneumococcal disease and non-bacteremic pneumococcal pneumonia among adults 65 and older. Also to examine the impact of indirect effects on pneumococcal disease trends in PCV13 naive adults, so those without PCV13 indications, a younger adult population, and to evaluate the impact of both direct and indirect effects on pneumococcal disease among the adult age group, 65 and older. As a reminder, in October 2017, at our ACIP meeting, the working group did update ACIP on changes in carriage and invasive pneumococcal disease among adults in this age group. Carriage rates were documented to be very low, 1.8% overall and 0.2% for PCV13 serotypes. And invasive pneumococcal disease caused by the PCV13 serotypes declined by 40% after introduction in children, and annual incidence rates have plateaued in recent years. At that time, the outline of the research agenda was presented to inform potential policy changes. So for today, you'll be hearing on 4 topics. First, PCV13 effectiveness against IPD among adults 65 and older by Dr. Pilishvili. PCV13 direct and indirect effects among adults 65 and older, again from Dr. Pilishvili. PCV13 effectiveness against pneumococcal pneumonia amongst U.S. adults and coverage estimates from Dr. McLaughlin from Pfizer, and estimating the burden of pneumococcal pneumonia among U.S. adults and the progress of the research agenda to inform potential policy changes from Dr. Madanak. So our question to our group today is to ask you, after you've reviewed this data that's being presented today, what additional information might you need to help determine whether continued PCV13 use in adults 65 and older is warranted in the setting of herd immunity from the childhood vaccination program? And I'll turn it over.
Thank you, and good morning, everyone. So I will be first sharing with you the results of studies evaluating pneumococcal vaccine effectiveness against invasive disease among adults 65 and older. PCV13 efficacy against invasive pneumococcal disease was demonstrated in a large clinical trial, CAPITA, where the efficacy was measured at 75% with a 41 to 91% confidence interval against PCV13 type invasive disease. And this was among adults 65 and older. Effectiveness of PCV13 alone or given in series with polysaccharide vaccine, as we recommend in this country for adults 65 and older, in the general population of in the general U.S. population has not been demonstrated, and therefore it is crucial to demonstrate effectiveness of this vaccine to inform future policy decisions. So to this effect, we conducted 2 case control evaluations. These were conducted in parallel using slightly different methodologies. So and I'm going to outline methodologies for each and share results as well as to compare the results of both. So the first study, in the first study, we selected population-based controls, and vaccination histories were assessed by contacting providers and through thorough provider record review. For the second study, this is a collaboration with CMS. We selected controls from Medicare Part B beneficiaries, and vaccination and medical histories for both cases and controls were obtained through CMS records. So just to remind you of the timeline of the vaccine introduction as it relates to the reference period for which we are obtaining the vaccination histories. So for children, PCV13 was introduced in 2010. In 2012, we had the recommendation for high-risk adults, adults with immunocompromising conditions, and in 2014 is when we recommended for all adults 65 and older. So on to the first study methods. So cases for this evaluation were identified through active bacterial core surveillance. These were invasive pneumococcal disease cases 65 years or older, and those with pneumococcal isolates available for serotyping were eligible for enrollment. We selected control that were identified through a commercial database called referenceusa.gov. And the goal was to enroll 4 controls per case, and controls were matched to cases on age group and zip code of residence. We conducted phone interviews for both cases and controls and identified all medical encounters in the past 6 years and their current and past medical care providers. We assessed information through interviews on the presence of underlying conditions, previous hospitalizations, as well as the certain household exposures, such as exposures to smoking. Then we, through these interviews, identified providers were contacted to obtain information on, for both cases and controls, information on the medical and vaccination history. And that included also if a case or control identified pharmacy as a place where they received the vaccination, we also contacted pharmacies and vaccine registries where available. We excluded from the analysis vaccine doses that were received within 14 days of case culture date. For the analysis, we grouped underlying medical conditions as follows. So when I speak about chronic medical conditions, we are referring to conditions such as diabetes, chronic heart, lung, or liver disease, alcoholism, and cigarette smoking. These are current indications for polysaccharide vaccine use for adults 18 to 64. And the immunocompromising conditions include HIV, hematologic cancer, generalized malignancy, immunosuppressive therapy, sickle cell disease, and asplenia. We measured vaccine effectiveness using conditional logistic regression adjusted for the presence of underlying conditions and race. And vaccine effectiveness was estimated as 1 minus the odds ratio. We measured vaccine effectiveness against various groups of serotypes, but vaccine effectiveness against PCV13 types as a group was our primary objective. So on to the results. So the table here presents a comparison of certain characteristics for cases and controls. We enrolled, to date, we enrolled 267 cases and over 1,000 matched controls. The timeline of enrollment, we started enrolling in October 2015, and the enrollment is still ongoing. The median age of cases and controls is around 75 years. We had a higher proportion of cases and controls of Black or other races, and we had the similar distribution of gender between cases and controls. 83% of cases versus 60% of controls had one or more chronic medical condition present, and 60% of cases versus 32% controls had at least one immunocompromising condition. And below there's a vaccination status of cases and controls. As you can see, the higher proportion of controls than cases received a single dose of PCV13. And this is receipt of PCV13 only. And for receipt of polysaccharide vaccine only or both vaccine received in series, we actually had either no difference or cases, a higher proportion of cases received 2 vaccines in series than controls. We looked at the serotype distribution of cases enrolled and compared to the same time frame for ABC's cases identified. And we have a similar distribution of serotypes where from PCV13 serotype 3 is the most common type. And then we had 7% that are due to, of cases that are due to other PCV13 serotypes, non-serotype 3. So serotype 3 is the most prevalent vaccine type remaining. And we also identified around 4% of serotype 6C, and this is a serotype that has been shown shown cross-protection through 6A antigen in PCV13, and therefore in some of the analysis we grouped it with PCV13 serotypes. And here are the results of effectiveness presented by vaccine type and by a serotype group. So on the left side is our outcome grouped by serotype group, and a number of case control sets for each of the categories presented that we enrolled. And the first column presents effectiveness estimates for a single dose of PCV13, and the second column for any PCV13 receipt. The cells that are highlighted in the white with a white background is where we would expect any effectiveness, and the vaccine effectiveness estimates that are in bold are the ones that where confidence interval does not cross the null value. So vaccine effectiveness against all IPD was measured at 37%, against PCV13 types at 65%. And when we included serotype 6C with PCV13 types, the estimate did not change, and the confidence interval was slightly narrower. For all PPSV serotypes, there was a 44% effectiveness, and again, PCV13 types are included in the PPSV serotypes with the exception of one. So there was some effect expected there because PCV13 types are contained in that group. And there was no effectiveness against serotypes that are unique to the polysaccharide vaccine for PCV13 dose and against non-vaccine serotypes. When we looked at any PCV13 receipt, the results were similar, slightly lower estimates, but the confidence intervals overlapped. And now on to the second method. So for this method, our starting point was, again, we identified cases of invasive pneumococcal disease through active bacterial core surveillance, but then we linked these cases to CMS Medicare Part B database based on limited demographic, geographic, and clinical variables. So after creating a linkage and identifying these cases within the Medicare Part B beneficiaries, we enrolled controls also through CMS Medicare, from CMS Medicare Part B beneficiaries, and the controls again were matched on age group, census tract, and length of enrollment in Medicare Part B. And we enrolled all eligible controls within the census tract of case and included all of them in the analysis. Vaccination and medical records, as I stated before, all that information was obtained through CMS data. And again, we excluded doses received within 14 days of case culture date. Very similar methods as far as the grouping of underlying conditions and the analysis of how the vaccine effectiveness was estimated. I won't go into the details. So for this analysis, we actually had the ability to go retrospectively. So the enrollment started with the cases that were from January 2015, and we were able to include 2 years worth of cases from ABCs and link them to CMS Medicare Part B beneficiaries. So from those, we were able to link 699 cases, and we matched over 10,000 controls. The median age, mean age is a little higher than in a previous study. It's around 78 years. Again, as in a previous study, we had a higher proportion of cases than controls of Black or other races, and a similar distribution of gender. We had a little higher proportion also compared to the previous study of cases with chronic conditions, 88% versus 58% among controls, and 54% of cases versus 32% controls had at least one immunocompromising condition. For the vaccination status, overall coverage through Medicare Part B data was lower, and that's something that when we measured the coverage, we were able to identify. But as far as the difference between the cases and controls, we found a similar pattern where a higher proportion of controls than cases had received a single dose of PCV13, and we didn't see the difference between cases and controls in terms of percentage receiving a single dose of polysaccharide vaccine or receiving both PCV13 and PPSV in series. We also compared the distribution of serotypes for cases that were included in the analysis versus during the same time period, cases that were identified through ABCs. And there's a very similar distribution, so there's no selection there going as far as which cases were included in the analysis versus identified through routine surveillance. And again, serotype 3 is the most prevalent vaccine serotype. PCV13 serotype. And onto the effectiveness estimates. So here, effectiveness against all IPD was measured at 24%, and confidence interval does not cross the null. For PCV13 types as a group, the effectiveness was 36%, but we did not, the confidence interval includes the null value. When we included serotype 6C, the effectiveness was 47% and significant confidence interval. And against all PPSV types combined, where PCV13 types again are included, 26% and not a significant confidence interval. And just to compare these two evaluations side by side, overall, the point estimates for CMS analysis were lower, but the confidence intervals do overlap. With the exception of for PPSV serotypes, we had much lower and not significant confidence interval. But overall, we found that the results were similar. And just to conclude, PCV13 was moderately effective in preventing IPD caused by PCV13 types. In the first study, we measured effectiveness at 65% and significant. In the second one, 36%, but not significant. Vaccine effectiveness estimates were similar when we included serotype 6C, some evidence of cross-protection. And PCV13 was not effective against serotypes that are unique to polysaccharide vaccine or non-vaccine types, which had no reason to be effective. And estimates we obtained in both studies were slightly lower compared to the vaccine efficacy estimates from the clinical trial, but the populations are different. Just to remind that in the capita, the immunocompromised individuals were excluded, as well as in our study, we had a higher proportion of adults with chronic conditions compared to the trial. And at this point, we're unable to evaluate vaccine effectiveness for polysaccharide vaccine or for PCV13 and PPSV given in series, but as I mentioned, the analysis is ongoing, enrollment is ongoing, so those are the secondary objectives that we are trying to address. So some of them listed here. We are really interested in looking at effectiveness when two vaccines are given in series for a polysaccharide vaccine against the unique serotypes, as well as looking at age group specific effectiveness, so whether there's any differences for elderly versus younger individuals. And I'll pause here, and I think...
Actually, Dr. Pilishvili, why don't you go on to your second presentation, and then we'll do questions after that, if that's okay.
Sure. So in the second study, this is something that we proposed that we are going to try to address at the time the recommendation was made. We realized, when the vaccine is introduced, we were observing these indirect effects from PCV13 use in children, and the question that this committee posed and many had on their mind is how you are going to be able to understand what is the contribution of direct effects from PCV13 use in adults versus continued indirect effects in adults from pediatric use of the vaccine. Again, just to remind you about the timeline, 2014 is where we introduced the vaccine for adults. So during this period of 2010 through 2014 is when adults are experiencing only indirect effects. And then since we introduced the vaccine, this is a combination of direct and indirect effects. And this latter portion is what we're trying to tease apart to understand the contribution of direct effects versus indirect effects. So our objective is to really understand what the experience through indirect effects among adults 65 and older would have been if we had not introduced the vaccine. And then, because what we're observing is the total effects, then we could at least from that understand what is the additional benefit through direct effects. So that's how we, I guess, approach this problem. If we can understand the counterfactual of like removing the vaccine and what the direct effects would be, maybe we can understand the contribution of the direct effects. So just to demonstrate using, and this is just like a drawing, and a dotted line is not like a real data, it's a fake data. But the blue line is what we observed, which is indirect effects in adults 65 and older. So if we were to use the pre-vaccine introduction, pre-2014 rates in order to inform what the indirect effects would be, we could project that information and predict, simply assuming the linear decline due to indirect effects, which would be this dotted green line. Then we would observe, and again, this is hypothetical data, not real data. Then we would observe, which is that blue dotted line, and that would be what we are observing is total effects, direct and indirect. And we could also utilize all the available data that we have through 2018. And then the difference between the two would be the contribution of the direct effects. So this is like a simplified, I guess, diagram to show how we were thinking or approaching, wanted to approach this problem. However, there's and I guess we will monitor the uptake of the vaccine to attribute it to the direct effects. But there are limitations to this approach. So assuming the linear decline in indirect effects is not appropriate because of what we know so far. So what we know based on post-PCV7 vaccine experience and indirect effects that we observed, as well as whatever indirect effects we observed after 13-valent, we know that most of the reductions happened in the first 2 years, and then there is somewhat of a plateau effect. So linear trends is not appropriate to assume and project indefinitely. And also because we're projecting and using the data only we only have 4 years of data. So because of that, our estimates would become less and less accurate over time, and the confidence intervals would get wider. So we realized that it's a very simplified approach to just take linear progression of indirect effects. So we used two different mathematical models, two different approaches to try to estimate the contribution of direct and indirect effects. So in the first approach, we utilized the pre-vaccine data as well as post-vaccine data, coverage data, PCV13 uptake. We controlled for seasonality, and we also used the observed data for adults 50 to 64 to inform us as one of the predictors in a model as what the indirect effects would have been among 65 and older. For the second approach, it's a more simple approach. We only used the pre-vaccine data among those 65 and older and 50 to 64 to understand their relationship in terms of how indirect effects are, how they're affected by indirect effects, and then project that relationship forward in order to understand what indirect effects in 65 and older would have been if we didn't have the vaccine. So based simply on the relationship between rates in adults 50 to 64 and 65 and older is what we estimated in a second approach. So for the first approach, we call it all or nothing model. And the reason this is called an all or nothing model is that there's an assumption. So we assume that the proportion theta of the vaccinated are not protected from disease or susceptible, and therefore 1 minus theta are 100% protected. So vaccine effectiveness can be estimated as 1 minus theta. So in this instance, if theta equals 1, then there is no protection from the vaccine, because everyone is unprotected, and so adults are experiencing only indirect effects. And so we are assuming that unvaccinated populations just continue to experience indirect effects only. So just to demonstrate, again, based on this assumption, how we would estimate what the size of the susceptible population would be. So the susceptible population is an unvaccinated population and theta times vaccinated population. So that's the blue portion, which is unvaccinated, and the shaded brown beige portion, which is theta times vaccinated. So those are our assumptions. So we use the pre-vaccine incidence in order to inform what the changes in the susceptible population would be. We use Poisson regression to model the rates among susceptible population representing indirect effects, and that's how we estimated the beta in a Poisson regression model, which is our parameter for indirect effects. However, then, unlike just using the only pre-vaccine data, the model utilizes post-vaccine data as well. And so this post-vaccine data then allows us to update the estimate. Given the beta, we estimate, again, the direct effects theta. And given the theta, we estimate the new susceptible population to update the estimate for the beta. So essentially, continuously, post-vaccine data continues to inform the model and gives a little more power to our predictions. So these last two steps continue until the model converges and we're able to estimate direct and indirect effects. So after we ran the model converged, we estimated the parameters. What is plotted here is based on the model predicted number of cases through indirect effects only. So if theta equals 1, we are only, the population experiencing only indirect effects. So that's a blue line. The red line is what we are observing in adults 65 and older. So based on the model prediction, indirect effects in the absence of the vaccine, and observed total effects is the red line. And so what we want to measure is the difference between the blue and the red line, which we would attribute it to direct effects or the vaccine use in adults. And so through these estimations, the calculations that are presented here in the table is during the period of time from the vaccine introduction in August 2014 through May 2017 is the latest data we have available. So we have 907 observed cases, so that's through total effects, direct and indirect. We predicted using a model that in the absence of the vaccine, there will be around 924 cases. So the difference between the two is 17. And as you can see, the confidence interval is very wide, and that's because we have very low case numbers and a lot of uncertainty in this model. But this is only for the ABC's population and during the entire time period, August 2014 through May 2017. If we project these estimates to the US population, then we estimated that during the same period, around 192 cases were prevented through direct effects. And if we translate that into average annual cases prevented, it's around 100 cases prevented annually, is what we estimated. Again, with a lot of uncertainty and very wide confidence intervals. So then we ask the question, because this essentially suggests that there's a flat line and there's not much happening. And so what would be happening in the background? And we looked at the serotype-specific changes. And serotype 3, which keeps coming up as like the most prevalent case, and we are also not seeing any impact on the population level, we try to remove the serotype 3 from our analysis. And when we remove the serotype 3, it looks a little better. We are estimating a little more cases prevented during the same time period, suggesting that for other serotypes there's a bigger impact than for serotype when we include the serotype 3. But again, very wide confidence intervals and a lot of uncertainty. And then on to the second method, where we are taking a more simplistic approach. So these are observed rates in 65 and older, presented in red. The green line represents 50 to 64-year-olds. So we build a model in order to relate the change in rates, in monthly rates in 65 and older to those of 50 to 64. And this is all pre-vaccine indirect effects only. And then using that model, we predicted, and that's a blue line here, of what indirect effects in adults 65 and older would be. And this is all based on the relationship with 50 to 64-year-olds, presented here in the green line. And so if we add the observed, which is the total effects, again, the difference between predicted indirect and the total effects is what we attribute to direct effects. And a similar table, and quite similar findings. I mean, the total cases prevented are quite low, but again, very wide confidence intervals using this method as well. And a similar exercise of taking out the serotype 3, which we see no changes in in trends over time, a little better impact on other vaccine serotypes, other PCV13 serotypes, but again, very wide confidence interval. So around 750 cases prevented during this period in US for the US population. So in conclusions, both of the models estimated that there are no additional indirect effects predicted in the absence of PCV13 adult recommendation. There are limited indirect effects when we take out the serotype 3 on other serotypes, but overall, as a group, PCV13 types, there are no indirect effects. There are limited direct effects observed in a setting of, I think we've reached around 40% coverage based on various estimates. But confidence limits are very wide and include the null, essentially no effect to some effect. And predictions are based on very small number of PCV13 type cases remaining after the indirect effects through pediatric use of PCV13. And obviously, IPD represents a small fraction of overall adult disease burden, and pneumonia is very important to consider in our projections of public health impact. So we are conducting a similar analysis to look at the direct and indirect effects on all-cause pneumonia as well. And that will be it. And I want to thank my colleagues that helped with all the modeling exercises.
Thank you. That was a great presentation. Really, really interesting. So let's take questions on both of these presentations. I think it's fair to say you looked for a needle in a haystack and you actually found a little bit, but a very, very difficult. Yes, Dr. Atmar.
I don't want to overinterpret this, but by removing the serotype 3 and looking like could be more cases of other PCV13 strains being protected against, does that mean that serotype 3 is, even though it's in the vaccine, is replacing these other strains? Or I mean, there's so much uncertainty that it would be premature to conclude that, but what do you think?
So I think to state that it's acting like a replacement serotype, it will be an overstatement at this point. But certainly, it's not behaving like any of the vaccine serotypes in terms of reductions that we see. And through the effectiveness studies, that's our goal, to enroll additional cases too. And we have more of serotype 3, so we're hoping to look at the effectiveness at the individual level also against this serotype. But as far as the trends and on the population level, it's essentially a flat line.
Dr. Szilagyi?
Yeah, that was a very nice presentation of a difficult topic, and you did find a small needle. I'm trying to relate the two presentations. It looked to me like the VE from the logistic regression was markedly affected by chronic disease and immunocompromise. It really, because the actual vaccination rates were very, very close. You found a small VE. And then in the second presentation, what is the vaccination rate among adults with chronic disease or who are immunocompromised? And might the direct effect be actually larger for that subgroup?
So I think the coverage estimates Dr. Matnock is going to share with you, but depending on the data we look at, it's around, I guess in the general population, around 40%, but it's all 65 and older. Among the estimates that I have seen for adults with chronic conditions, it's focusing on younger adults with indications, and I'm not sure that we have information on 65 and older with chronic conditions, but these estimates were provided by colleagues at Pfizer, and if their data allows it, I'm sure they will be able to estimate that for 65 and older with chronic conditions and to see whether there's a difference.
Just to build on that, I know you controlled for the presence of chronic conditions and immunocompromising conditions, but did you look actually at the analyses separately, stratified by that?
We tried to look, but at this point, because of the numbers, the confidence intervals are, yeah.
Other questions? Dr. Belongia.
Thank you. Can you just, on the first two case control analyses with the two different control groups, can you just clarify, my understanding is this is a in-progress analysis, the study's not complete. What is the overall sort of endpoint in terms of sample size and power, and when will that analysis be done?
So I think the power estimation, when we conducted the sample size needed estimation, we needed around 46, 45 cases in order to be able to estimate vaccine effectiveness against PCV13 type. But that was in a setting of a 30% coverage. So we have not redone these calculations. And another thing to take into account is the study it's a little bit tougher to apply those sample size calculations to our methodology because, first of all, it's over time and the coverage is changing over time. And second of all, we're using conditional logistic regression. So only discordant sets on vaccination status will be contributing. So earlier on, when we have lower coverage, we might have more concordant sets, and later on more discordant, et cetera. So we think that through another winter of enrollment, we will have sufficient numbers to, through winter 2017-18, we would have sufficient numbers to look at these additional endpoints. But for PCV13 types, we don't think that we have sufficient, we think that we have sufficient numbers to at least believe the estimates we're seeing.
Dr. Stevens.
Just to clarify this serotype 3 issue, when you look, and maybe you've not done this yet, when you look at the effectiveness of your studies against specifically serotype 3, what is the data?
So for serotype 3, there are immunogenicity studies that suggest that the response may not be as good against that serotype. And there are studies in pediatric populations that also show that it's not quite effective.
Sure. Now, I'm specifically asking about the studies, your vaccine failures. Are they mostly serotype 3s, or we don't know that yet?
So in pediatric population vaccine, are you talking about adult population?
Talking about the data.
These data. So we have not looked at it from the standpoint of the failures, but it's among cases the vaccine type serotype 3 is the most prevalent, and it's most prevalent as far as the prevalence of like causing disease as well. So it's in vaccinated and unvaccinated. But we have not looked at in terms of adult failures. In pediatric failures, we do see serotype 3.
Dr. Lee.
Can you remind us, for the controls for the two case control studies, the time period from which those controls were sampled?
So the controls are sampled simultaneously with cases, but they are matched on age to cases. And then the reference period is matched to case culture date. So case culture date for corresponding controls is our looking back, where look back period starts for controls as well. So they are interviewed with respect to that time period, as well as the vaccination status is assessed with respect to that period.
Great, thank you.
Ms. Pellegrini.
Thank you. Were you able to look at all at severity of disease? Like, was there hospitalization, or was hospitalization shorter?
Not at this time, but we will be able to look at that. As part of the first case control study, we have information on prior hospitalizations. We have current hospitalization information as well, and we are also asking questions in terms of functional status of these adults. So that's a subsequent analysis.
Dr. Atmar.
I know the goal first is to show effectiveness that's significant, but are you going to be able to look at effectiveness over time as you get more people enrolled in or more cases in the study?
Over time of enrollment, or
over time since PCV13 became available. So in other words, addressing kind of the question of the direct versus indirect effects, but were there greater effects early on, and over time those effects became either larger or smaller?
Yes, we should be able to do that, and that's actually one question we're exploring, because as I mentioned, for CMS study, the enrollment started much earlier when the coverage was lower, and we do have slightly different estimates between the two studies. So what we wanted to do, at least with the CMS analysis, is to limit to the time period of the second study and see how they compare. So in a way, like indirectly addressing that question.
Okay, I think we'll move on to Dr. McLaughlin. Thank you very much, Dr. Pilashvili.
Okay, so good morning. My name is John McLaughlin. I'm the lead epidemiologist for pneumococcal vaccines at Pfizer. And I'd first just like to start by thanking the ACIP and the working group for giving us the opportunity to present these data that we've been working in collaboration with the University of Louisville to collect for over approximately the last half of a decade. Okay, so my talk will focus on two main things today. The first thing that we'll talk about is real-world vaccine effectiveness of PCV13 against vaccine-type community-acquired pneumonia. And we'll do that by looking at a case control study that used a test-negative design, similar to what we saw in the influenza studies yesterday, in U.S. adults. And this study was conducted and nested within a large population-based surveillance study of community-acquired pneumonia patients in Louisville, Kentucky. The second thing that we'll focus on is this question that everyone has really been asking, is can we somehow disentangle these direct effects of the vaccine from indirect effects that might be stemming from the pediatric immunization program? And we'll take a pretty straightforward approach to try to answer that question. We'll really compare PCV13 uptake in two groups of adults and contrast that with the burden of community-acquired pneumonia that remains PCV13 type. And the two groups that we'll look at is adults 65 and older, who are routinely recommended to receive the vaccine after September 2014, and then another group that's essentially served as a control group in many ways, which is the group of adults who are less than age 65, who are immunocompetent, but have other underlying chronic medical conditions and are currently only recommended to receive polysaccharide vaccine. And the other thing to underscore is that for all these analyses, we'll be looking at community-acquired pneumonia, which was the primary unmet medical need for PCV13 based on licensure and recommendation. So on the first topic, we'll just look at we wanted to look at the effectiveness of the vaccine. And as we heard before, we know that the efficacy of PCV13 against hospitalized vaccine type CAP was previously demonstrated in a large randomized controlled trial. The CAPITA trial enrolled almost 85,000 adults and found statistically significant efficacy of the vaccine against vaccine type pneumonia. But vaccine effectiveness, specifically against vaccine type community-acquired pneumonia, hasn't been shown in any study since the routine introduction of the vaccine in an immunization program. And the US is one of the few places we can actually do a study like this. So that's exactly what we set out to do in collaboration with the University of Louisville. So you may have seen this recent publication. This study kind of outlines the early phases of the Louisville data published in CID. And you'll note that essentially there was a large population-based surveillance study. It enrolled all adults who are aged 18 and older, living in Louisville, Kentucky, who are hospitalized with community-acquired pneumonia. This was done at 9 adult acute care hospitals throughout Louisville, Kentucky, and really represented a full catchment area of the Louisville population. These are all 9 adult hospitals. This is the time frame for the study. The important thing to note is that it includes time periods both before ACIP recommendation in adults 65 and older, and after ACIP recommendation. The other thing that was important about this study is that it collected urines for all enrolled patients, which allowed the conduct of the Pfizer PCB13 serotype-specific urinary antigen detection assay, or the UAD, which can essentially tell whether or not PCB13 serotypes caused a hospitalized case of community-acquired pneumonia. Now, one of the first major findings in this publication was that if you calculate age-standardized incidence rates of community-acquired pneumonia, the Louisville Pneumonia Study found a much higher incidence rate of CAP than in previous studies. For example, in the 65-plus population, the Louisville Pneumonia Study suggested that the incidence rate of CAP, of hospitalized CAP, was roughly 23 per 100,000. If you contrast this with the earlier publication of the CDC's EPIC study, the estimate, using very similar methodology in age standardization of incidence rates in that same age group, was only 900 per 100,000. So there was originally a lot of questions about why the discrepancy between these two estimates and two prospective studies that were relatively similar in how they enrolled patients. And so we spent a lot of time trying to figure out why there was this discordance between the two studies. So the first thing, this represents essentially that 2,300 per 100,000 number, and what we realized is it was really a function of the difference in selection criteria between the two studies, and not just in selection criteria, but two specific selection criteria in the study. So those two selection criteria were whether or not patients with healthcare-associated pneumonia, so these are patients that had interaction with the healthcare system in the last 90 days, so think skilled nursing facility, nursing home patients, and also whether or not immunocompromised patients were included in the study. And what was remarkable is if we applied the same selection criteria that did EPIC to the Louisville study, the EPIC study excluded HCAP and immunocompromised, we got almost an identical number to the EPIC study. And so it really became clear that these HCAP patients and these immunocompromised patients are what's explaining the discrepancy between these two studies. It's not that they're vastly different in methodology, it's just these two selection criteria. So this is the study that our test negative design was nested in. This is the time frame that we showed before, and this is just to help orient you to where our test negative design sat within this broader Louisville study. So here's the time frame of the study. It's enrolling all adults who are hospitalized with community-acquired pneumonia. This is essentially when the recommendation happened and adults 65 and older began using the vaccine. And so we had this time period now where we could actually look at adults with community-acquired pneumonia. We had PCB13 serotype information on them because these adults were providing urine samples that we could test with UAD. And then we were able to go back and look at the vaccination status for all of these patients and call their health insurers and figure out whether or not they were vaccinated with pneumococcal vaccine. And this was the time frame for our analysis. So this is the definition of community-acquired pneumonia. In the Louisville study, patients had to have 2 or more clinical criteria for pneumonia. They had to have radiologic evidence of pneumonia. And then we excluded few patients. Patients with hospital-acquired pneumonia, but not HCAP, were excluded. Patients were excluded if they didn't have a final diagnosis of pneumonia at discharge, and patients were excluded if they didn't supply a urinary sample for testing. We applied a slightly, another layer of selection criteria for the specific test negative design. We restricted the analysis to patients who were 65 years and older, given that's the group for whom the recommendations were made, and we knew there would be vaccine uptake there. And then there was another layer of consent. These patients had to provide additional consent for us to go back to their health insurers and get validated vaccination status. We excluded only 2 types of patients in the analysis phase. If we couldn't reach their health insurer, meaning we couldn't ascertain valid exposure status for these patients. And secondly, we excluded patients if they had a pneumococcal vaccine, but it was given 30 days prior to the urine sample, given there was a recent publication that suggested you could get a false positive in the UAD if the vaccination occurred too shortly to that. So it was just to be conservative. So this is how we define cases and controls in our test negative design. Cases were essentially, so all of these patients are hospitalized with community-acquired pneumonia. Remember that part first. And then cases are essentially any patient where we find a PCV13 serotype either by culture or by UAD. And controls in the primary analysis are essentially everyone else. We also did a sensitivity analysis where the case definition stays the same, and we essentially split this control group into two separate groups just to make sure that there's no impact of how controls are defined on the analysis. In the first sensitivity analysis, controls are defined as non-PCV13 type pneumococcal cap, so the whole analysis is restricted to pneumococcal cap patients. And the second sensitivity analysis is really just the inverse of that. It's patients who don't have PCV13 serotypes identified, and they're non-pneumococcal cap patients. Here's a look at our participant flow chart. So there were almost 4,200 adults aged 18 and older hospitalized with community-acquired pneumonia during the time frame of our test-negative design analysis. You'll remember that we restricted the analysis to adults 65 and older. That left us with 2,048 hospitalizations among adults 65 and older. And then we only had the two exclusion criteria where we essentially excluded patients without valid pneumococcal vaccination status. And you'll see that the Louisville team did an amazing job ascertaining vaccination status. They excluded less than 10% because they couldn't get vaccination status for them. And then secondly, we excluded the patients that had pneumococcal vaccination, but it occurred too quickly to the urine sample collection. That left us with a final analysis population of 2,034 adults who were 65 and older with hospitalized community-acquired pneumonia. So this is a look at what those 2,034 adults included in the study look like. It's kind of a busy slide, but there are a few key takeaways. Number one, this is an older population. The median age was 76 years, and more than a third of them were 80 or older. And that's not surprising given these are all patients who are hospitalized for CAP. 46% of these patients were immunocompromised, so they had some type of immunocompromising conditions. And another 42% of them were immunocompetent, but had other underlying comorbid conditions. And you can see the proportion of some of the comorbid conditions there. If you're wondering why the proportion of some of them is higher than the total at-risk number, those proportions include adults that are both at-risk or immunocompromised. The other thing to note is that the median length of stay for these patients was almost a week. It was 6 days. And the in-hospital, or in the mortality rate ranged somewhere between 7% and 13% for these patients, depending on if you measured it as in-hospital mortality or mortality within 30 days. This is a look at vaccine coverage for these patients. So remember, this is a time frame pretty soon after the recommendation. So the average PCV13 uptake was 14.2% in this study. You can see the proportion that, and that's in the last 5 years. You can see the proportion that received polysaccharide vaccine in the last 5 years, and you can see the proportion that received both pneumococcal vaccines in the last 5 years. And then the self-reported influenza vaccination receipt in the year prior was 68% for these patients. We were reassured to see, when we looked at the most recent CDC MMWR of estimates of vaccine uptake, if you compare the same time period from that publication to the time period in our test-negative design, it was really comparable. So we think that the team at Louisville did a nice job ascertaining PCV13 uptake data because it was very comparable to what was seen in the recent MMWR. So this is the flow chart you saw before. We talked a little bit about what the 2034 overall population looked like. Where did we identify PCV13 serotypes? So we identified PCV13 serotypes in 68 of these patients, either in UAD or culture, and in the primary analysis, all of the other patients served as test-negative controls. We had UAD and Binax available for everyone, since that was part of the inclusion criteria, and culture was available, which was mostly blood culture, for almost everyone. Culture results were available for 94% of the population. Here's what our 68 cases look like. 66 of them were identified by the PCV13 specific UAD. 8 of them were identified by culture. Only 2 were identified by culture alone. A couple of things to note based on this is that the UAD increased the detection of PCV13 serotype 6 times compared to culture alone. And if you compare it to just blood culture alone, it was 11 times. And one of the key takeaways from this, even though the UAD was really designed to help us understand effectiveness and efficacy, as an epidemiological tool, it really showed that this idea of 3-to-1 non-bacteremic to IPD ratio may actually be underestimating, as we saw a ratio closer to 10-to-1. So this is essentially our 2-by-2 table. This is cases and controls by vaccination status. There are two things to really note on this slide. One, there were very few cases of PCV13 type disease among people who were vaccinated. There were only 3 cases among vaccinated persons. And secondly, the proportion of cases that were vaccinated was less than the proportion of controls who were vaccinated. This translates to an odds ratio of 0.272 that's statistically significant, and calculating VE as 1 minus the odds ratio as standard leaves a vaccine effectiveness estimate of 73% against hospitalized vaccine-type community-acquired pneumonia with the confidence interval that doesn't cross 0 that you can see there. The next thing that we wanted to understand, this is a busy slide, but there's really only a couple of key takeaways. We wanted to understand, is this vaccine effectiveness modified by confounding for all the different variables that we looked at? And secondly, is this vaccine effectiveness estimate similar if you restrict the analysis to non-bacteremic pneumonia only, so essentially restricting out all the invasive cases? The answer to those two questions is essentially yes. You can see that no matter what we adjusted our crude estimates for, whether it be seasonality and time period, age group, risk level, previous vaccination with polysaccharide or influenza vaccine, these point estimates were very consistent throughout and really didn't change. And the crude model served as our final model throughout because there was no evidence of confounding in any of our models. And you'll also note that the estimates for non-bacteremic effectiveness were very similar. The final model also statistically significant. And it's not surprising given that 92% of all the cases in this analysis were non-bacteremic. So the final thing that we looked at was if we do a sensitivity analysis of how we define cases and controls, do you get different results? And the answer to that question was essentially no also. So you can see, depending on how you define controls here, that the vaccine effectiveness estimate, point estimates are very similar across each sensitivity analysis. The first sensitivity analysis, if you remember, restricted it only to pneumococcal cat patients. And we lost almost all of our controls. We lost almost 1,900 of the controls. So we were underpowered in this analysis. But that's given that the UAD, which really increased the sensitivity for detection, isn't available for other non-PCV13 serotypes. So we really were limited to only culture and Binax for controls. So in summary, the vaccine effectiveness study showed that the vaccine is effective against hospitalized community-acquired pneumonia in older adults in a population that includes immunocompromised patients and HCAP patients, that vaccine effectiveness estimate was robust to adjustment for confounding for all of these different variables, which is really a testament to test negative designs and their ability to help mitigate some of that type of bias. And it was also robust to how we defined controls. The point estimates were all similar throughout the analysis. So just to transition a little bit, the next thing we wanted to look at after effectiveness was, can we start to tease apart direct effects that we're seeing from indirect effects? And I've talked a lot about Louisville. That's where we had a population-based study, so we could think about incidence. We also had vaccine history data in this population, so we could look at vaccine effectiveness. But the surveillance study of community-acquired pneumonia that also got urines on these patients and looked at the proportion of disease that was vaccine type was bigger than just Louisville. It included a lot of sites outside of the United States. And so this was the group of patients from which we'll start to look at what proportion of all-cause CAP is vaccine type. And you can see it's a very large number of patients as well. Over 12,000 patients hospitalized with community-acquired pneumonia. And we contrasted this with PCV13 uptake data that's been presented in previous meetings that essentially looked at quintiles IMS health claims for PCV13 data, and we'll show that in just a second. So we'll first start with the 65 plus population. This shows uptake of PCV13 based on administrative claims data over the time period that's both pre and post ACIP recommendation. And it's clear that the recommendation had a big impact on people getting vaccinated. And you can see on the far right y-axis the coverage over time represented in the gray bars. And also it's important to note that our coverage estimates here are almost identical to the estimates from the CDC MMWR report. And the next thing we wanted to do was, what if we overlay the proportion of all-cause community-acquired pneumonia that's vaccine type over these coverage estimates? And that's what we did, and you'll see here. So in the blue represents the time period before the ACIP recommendation. The red represents the time period after ACIP recommendation. And then we constructed linear trend lines that you can see here. The important takeaway is that before the ACIP recommendation, the proportion of disease that's vaccine type is sticking around at somewhere between 4 and 6%, which is consistent also with EPIC estimates that used the UAD in an earlier time frame and not changing, and that the proportion of community-acquired pneumonia that's due to PCV13 serotypes then begins to decline in adults 65 and older, corresponding with the uptake of the vaccine, and that was statistically significant with a p-value of 0.01 that you can see here. So the next question is, are these due to direct effects of the introduction of the vaccine, or is this indirect effect? And the way to essentially help answer that question was to compare this to another group where the uptake is much lower, where the vaccine isn't recommended. So that's exactly what we did here. We looked at the 18 to 64 at-risk population, again, the population that's recommended to only receive polysaccharide vaccine. Not surprisingly, the uptake in the gray bars is very low. And then we compared the same thing, the proportion of all-cause cap that's vaccine type both before and after ACIP recommendation. And you can see here that the two trend lines are both much more flat, staying between that same 4 to 6% and not decreasing as we saw in the 65 plus population. So this was the first hint at the idea that the vaccine is having an impact in the group that has higher vaccine uptake. So in conclusion, we saw that the vaccine has real-world effectiveness in a population that included HCAP and immunocompromised adults. This was done in the same study that also showed that the burden of community-acquired pneumonia is higher than other studies, including HCAP and immunocompromised patients. The other thing that I will note, I didn't present serotype specific results, but 40% of the patients in this study, the disease was caused by serotype 3. And our initial estimates of serotype 3 did show vaccine effectiveness, and point estimates, they weren't statistically significant. But what we really think is it's consistent with estimates from the pediatric data that have shown effectiveness against serotype 3. Results from Capita and our study had positive point estimates against serotype 3, roughly 50%, though the study was underpowered. But what really seems to be happening is there is limited indirect effects against serotype 3. So the force of infection is increasing. And so what that really means is serotype 3 may be acting as a replacement serotype, but there is some level of direct effectiveness in adults. And finally, we've seen that if you compare PCV13 uptake to the proportion of all-cause community-acquired pneumonia that's vaccine type, you see a clear difference in two groups, one being vaccinated, one not being vaccinated. So following PCV13 recommendation in adults 65 and older, PCV13 uptake has increased corresponding to reductions in vaccine type cap. Where PCV13 was not used, for example, in the 18 to 64 at-risk population, vaccine type cap has not decreased despite indirect effects and is plateaued at a consistent level. And then finally, PCV13 serotypes still cause around 3 to 5% of CAP in unvaccinated adults. And the real question is that even a meaningful amount of disease? But if you account for the overall incidence rate of roughly 2,300 per 100,000 in adults 65 and older, for example, and multiply that by the 3 to 5%, that still means there's an incidence rate of PCV13 type community-acquired pneumonia of somewhere between 69 and 115 per 100,000 in adults 65 and older. And if you translate that to the 49 million adults who are 65 and older in this country, that's somewhere between 150 and 250 hospitalizations if you take a 5-year time horizon where this vaccine has been shown to be effective, and somewhere between 10 and 30,000 deaths. So with that, I'd like to thank the working group again for the opportunity to present and take any questions.
Thank you. I'm afraid we have limited time for questions because that was a little longer than we expected. But do people have some burning questions? Yes, Dr. Hunter.
When I was practicing clinical hospital medicine between 2005 and 2010, the urine testing that we were doing for pneumonia wasn't very clinically effective, in my opinion, in how it was used, at least in Milwaukee. I was curious if you or if anybody else could comment on the urine testing that you're doing and whether that is more clinically effective and really is something that can be used to make population-level decisions.
Yeah. So the assay, as you saw in our study, really does seem to increase the sensitivity of detection of pneumococcal serotypes. And in fact, as you saw, it increased compared to blood culture alone or to just culture alone, somewhere between 6 to 10 times the increase in sensitivity. So it really is an important tool.
Dr. Stevens.
So I want to follow up on that.
Sure.
Can you give us some sensitivity and specificities of the UAD in normal populations where this has been a concern? High colonization rates sometimes will give you positivity. Can you comment on that?
Yeah, it's a great question. So if you look at the most recent EPIC publication, for example, that was just published in CID, they looked at the sensitivity and specificity of the assay and found 95% sensitivity and 100% specificity using a gold standard of invasive pneumococcal disease. So it also confirmed previous studies for validation of the assay. So those are essentially the estimates, very high sensitivity and specificity.
Dr. Atmore.
I guess to follow up on that question, does carriage, nasopharyngeal carriage, give a positive UAD test?
Yes, so it's also a good question. For all of the UAD studies, control patients are enrolled, and there's a baseline detection that's done in these control patients, and if any positivity is seen, the cutoffs can essentially be adjusted. And that's been built into the assays since the very beginning. So there is a baseline adjustment made for any carriage seen in a control population.
Any further questions?
Well,
Dr. Lee.
Thank you. The question of immunocompromised, so this incorporated the immunocompromised population.
Yeah.
It might be helpful to actually take that out since those people would presumably receive vaccine anyway,
yeah.
And focus on the population of interest. So were you able to look at that?
Yeah, so you mean for the vaccine effectiveness estimates? So we did do that. As in the previous presentation, we were really restricted based on the fact that there were only 3 patients and doing 3 patients who were vaccinated who also had a failure to really look at all the stratified analyses. But point estimates, regardless of how you stratified the results, were really consistent throughout, always somewhere between 60 and 70%, regardless of the patient population analyzed.
Dr. Belongia.
Just briefly, can you just clarify what was included in your final adjusted model? You listed 13 different univariate comparisons, and then you had a final adjusted model. What was in the final model?
So the fully adjusted model or the final model?
The fully adjusted model.
The fully adjusted model included everything you saw on that list. So it essentially put everything in the model.
Okay. Thank you very much. Any further questions? Okay. I think we'll move on to Dr. Madanach.
Good morning, and thank you. I'm going to discuss estimating pneumococcal pneumonia burden and then wrap up this session with a summary of the progress on the research agenda that Dr. Lee mentioned in her opening. As has been noted, pneumococcal conjugate vaccines have dramatically reduced invasive pneumococcal disease in adults through indirect effects. ACIP recommended routine use of PCV13 in series with PPSV23 for adults aged 65 years and older in 2014.